Good afternoon, everyone. I hope everyone is having a fantastic day as I am. My name is Jinu, and I'm a client partner at Nalasha. Firstly, I would like to thank all of you for joining us today for the webinar. We have planned this educational webinar to help you understand the recent changes in the home health market. In the interest of time, we plan to skim through the previous standards like the conditions of participation for 2018, and we would be taking a deeper dive into the home health new rule for 2019. I believe some of you have been a part of our previous webinars around COPs. However, in this webinar, we cover the changes and also help you with the suggestive approach that can be taken. Most of our previous webinars have been technology focused, and since we've noticed a lot of agencies participating in these sessions, this webinar throws light onto the changes as a whole and then talks about the technology components. So we all know the reason why the US government is coming up with these aggressive timelines and all these harsh sudden changes for our market. This was exactly what the traditional EHR market faced a few years back. With the value-based care wave, quality has been given the primary priority and is linked to the performance and the incentives of the providers. The approach to be taken that we would suggest during this webinar comes from our experience in working around the value-based care and the home health market. And during the session, we will have a few polls in between for all the attendees, and I would request all of you to answer them so that we have an understanding about your thoughts and about what each one of you plan with reference to these new changes and how your experience was with dealing with the one last year. And during the course of the presentation, we would only be taking questions through the chat window that you see on the GoToWebinar panel, where you can type your question and send it over to us. We will be sure to get that answered either immediately or towards the end of the session. And post the presentation, we have planned a 10-minute Q&A session where an attendee who has a question can raise their hand again from the GoToWebinar panel, where you will have to click on the hand icon, which is on the top left side of the panel below the mute button. We will then unmute the attendee and you can go ahead and speak your question, which will be answered by our speaker. The purpose of this webinar is to educate and to prepare everyone with the new home health rules. And though this is a live webinar, please do note that this is not a discussion. We will have all the attendees on mute and will be unmuted only during the Q&A session. That is, if you raise your hand and you have a question. So before I introduce our speaker for today, there's a quick poll that we all have for you. This is just to understand your thoughts around the changes, as this is the very first time the home health market is being hit with such a big revamp. Yeah. Thanks a lot, everybody, for answering the poll. All right, then. Now I would like to introduce Kirti, who is our speaker for today. Kirti comes from a healthcare background and has spent more than a decade in the provider space. She has been a key part of all our clinical endeavors, where she heads the functional components of all the clinical workflows and all the standards. So, ladies and gentlemen, grab your coffees, sit back, and I hope all of you have a meaningful session and in the end, have something to take away from this webinar, which will help you plan around the series of changes that have been and will hit us in the upcoming time. Over to you, Kirti.
Uh, Thanks, Gino. Good afternoon, ladies and gentlemen. So today we are going to go through 2019 final rule for home health, patient-driven grouping model, its approach, calculations, and impact on the systems. Then we will take a look at the prospective payment system, a couple of changes which happens every year in terms of the rates and case mixes. Then we will look into value-based purchase changes and overall changes in terms of quality reporting. Moving on to the context. CMS is driving towards value-based payment system, focusing on patient needs than to volume of care. Uh, so, so the needs during driving towards the patient-centric approach to deliver quality care for better outcomes. Now, who is getting impacted with this? Definitely the home health agencies, their systems, and their processes. which means while the processes are taken care by the home health agencies, the system needs to be updated with the workflows to be in line with the regulation. So, not just the agencies, we also think the ISVs are also going to get impacted. So, let's take a quick uh, recap of the types of changes the system have gone through as part of the COPs and what are the details about it. So some of the changes are with respect to the continuous and integrated care processes, patient-centered approach, patient-driven grouping model to make the grouping more diagnostic and based upon the conditions of the patient, emphasis on the quality improvements, and to make all this information exchangeable between different providers, agencies, the patients and their respective auth reps to make everything transparent. And then infusion therapy is another change. So while these are the changes that we will deep dive during today's discussion, let's take a quick look at COPs. Uh, so I just want to have a recap of the type of changes, the systems that have gone through as part of the COP implementation, which should be ready by January 2019 this year. So the core objective is to improve the quality of healthcare services for all the home health patients, protect and promote the patient rights. Uh, this also specifies that that agencies to focus on care provided to patients and track the impact of the uh, co- core outcomes of the patients, which means enhance the processes of care planning, delivery, coordination of services, building a foundation for data-driven quality improvement as well, which means it's not just administrative changes, but also the clinical workflow changes and the detailed amount of information that needs to be captured for every patient. So while doing this, the whole intent was to introduce best practices to achieve outcomes based on care. However, this has introduced a lot of challenges at every stage, right from identifying the designated staff, training them with all the new workflow changes, making sure that the outcomes are tracked correctly, the quality is observed, and again, it is tracked in the system and submitted. So while all your systems are ready for COPs to start using, we just want to reiterate on some of the good processes which will improve all this requirement or overall performance of your systems and your day-to-day activities. One such is a good alerting system which notifies the users on respective intervals that they have to perform respective actions for the patients. So good alerting system within the system should which helps the users to do the respective actions will definitely improve their day. Uh, then a versioning of comprehensive assessments, making tracking every possible change in the treatment plan of the patients will not only help in quickly tracking the quality reporting measures and things, but also it helps in the submission and getting better payments as well. Now, the other one is interoperability, uh, where the information can be transparent and exchanged with all the respective parties. So these are some of the suggestions that we would say that should be there in the systems to improve the overall process. So we look at every change as an opportunity so that it improves everybody's activities and helps patients to get better care. Moving on to moving next, before we take a deep look into 2019 changes, we have a quick poll question coming in. Thanks for that. Now moving into 2019, what next? We have identified a couple of the major changes or the processes that are going to majorly impact the workflows and the systems. The first one is patient-driven grouping model. This actually brings a more detailed case mix weights based upon the patient conditions, which will decide how many visits are required for the patient, and then the payment periods are going to change from 60 days to 30 days, which means the billing systems needs to be updated uh, to submit the respective claims within 30 days and to track all the conditions of the patient on the claims and their respective care plans and quality data as well. Then moving next, one of the biggest change is remote patient monitoring. CMS believes that remote patient monitoring is very beneficial. The cost associated with the patient monitoring devices can be identified as an allowable administrative cost or an operating expense from going forward. The purpose of this is to improve care planning, and remote patient monitoring is a method of healthcare delivery that uses latest advances in information technology to gather the patient data outside of a healthcare setting. Previously, Medicare beneficiaries were eligible for telehealth services only if they are present from an originating site located either in rural health professional shortage area or in a county outside of a metropolitan statistical area. But going forward, one of the major observation is remote patient monitoring without direct interaction is statutorily considered as a telehealth service, and uh, this will be going forward. This can be paid by Medicare. So, respective codes, CPT codes, and modifiers are introduced. So, then the changes are required to be done to the billing system so that these can be submitted and the care can be uh, uh, given to the patients. Uh, the next major change is the home infusion therapy. As per the new rule, it has become a mandate for the infusion therapy suppliers to select a CMS approved accredited organization to undergo a review or a certification to meet the AO standards, which means this allows them to receive the payments from Medicare as long as they are certified. With the respective AO agencies. So while this is one of the rule, there are other four rules that needs to be followed. The patient should be under the care supervision of a physician or a nurse practitioner or a physician assistant. All patients have a plan of care established and updated by the physician that sets out the care and presented infusion therapy necessary to meet the patient needs. Then providing patients with necessary education and training. Monitoring services so that it is monitoring or remote monitoring services to make sure that the treatment or the infusion is done properly. Now, there are a considerable amount of changes in terms of payment systems to achieve this. Uh, the temporary for 2019 and 2020, there is a temporary transactional payment that is going to be introduced for the services that are furnished by the eligible supplier in an individual home to an individual based on the need. So for this, there are three payment categories or rules. Coming to the category one, it includes antifungal and antiviral uninterpreted long-term infusions, pain management, isotropic and chelating drugs. Whereas under category 2, subcutaneous immunotherapy infusions will be considered. Under category 3, certain chemotherapy drugs will be considered. Equal amounts or the amounts of statutory specified codes only will be paid. under the respective quantities. There is no geographic adjustment to these payments, and the new rule include payments for home visits as well. So the provider has to submit the length of home visit on the claim, and it is expected to be between 1 to 6 hours. Now, with the billing changes with respect to RPM and infusion therapy, PDGM, etc., have brought a lot of regulation. So the whole billing system, or the way the calculations are happening, the rules and everything will get modified. So not only the billing team needs to be educated about it, but also the system should have the validations so that it alerts them with the right codes and the right details, helping them to get better payments. Then moving on to the next one, with respect to prospective payment system, 2019 is a transition year because it's going to move into patient-driven grouping model. That's one of the major change. Then the market update is identified as 3%, and the CMS identifies the multi-factor productivity adjustment as 0.8%, which is removed from 3%, ending up with 2.2% standard payment increase, which means last year's episodic standard payment rate, which is at 3,039.64, will be increased to 3,154.27 in case the agency is doing quality reporting. However, if the agency is not doing that, then the 3,039.64 will be increased only to 3,092.55. There is a change in the fixed dollar loss, which gets changed from 55% to 51%, which means the outliner's cost is going to be capped at 2.5% of the total cost. This year also, the adjustment case mix weight is going to follow the budget neutral approach. So whoever is performing will have payments, and people who are not meeting the benchmarks or the thresholds will face penalties. There is no major change with respect to LUPA. But I just want to reiterate one point. The first visit of the LUPA episode, be it for SN or PT or SLP, the episode should be uh, with the patient. Uh, then moving on to the next slide. Coming to rural add-on changes, now it is back again, which is the good news, but this is extended till 2022. So in the rural add-ons can be applied based on the county. The county is categorized under three varieties. The first one is high utilization counties. The second one is low population density HHAs, and the third one is the others. So for 2019, for high utilization counties, 1.5% is applicable. For low population density HHAs, 4% is applicable, and for others, 3%. Moving on to 2020, it will be slightly reduced, where high utilization counties would be at 0.5%, low population density would be at 3%, and others would be at 2%. Moving on to 2021, low population density would be at 2%, and others would be at 2%. And for 22, only the low population density HHS will have 1%. Add-on. Uh, uh, Coming to the claims, when the rural add-on codes are applied, you have to introduce the value, you have to report the modifier code 85 on the claims, and the state and county codes of the place of residence where the home health services are rendered should also be mentioned. While these are some of the changes to the rural add-on codes, then moving on to the next. Value-based purchasing. Coming to value-based purchasing, it's going to remain in the same 9 states as last year. And it's going to follow the same linear adjustment approach as I spoke before. However, there are some changes to the quality measures. So as the priority areas for a value-based purchase is quality of care, care coordination, population and community health, uh, caregiver-centered experience and outcomes, safety, efficiency and cost reduction. While these core areas remain the same, there are slight changes to the measures. So two measures with respect to influenza vaccine and pneumococcal vaccine are removed. Three measures are replaced with two composite measures. One of them is total normalized composite change in self-care, total normalized change in mobility. Now, as you see, they are composite measures, which means they are calculated based on a couple of other measures. So the first one, composite change in self-care, is calculated based on 6 ADL activities like grooming, upper body dressing, lower body dressing, bathing, total hygiene, eating habits. The normalized change in mobility is dependent on improvement in toilet transferring, improvement in bed transferring, improvement in ambulation and locomotion. So these are calculated cumulative of these sub-measures, and the totals will be applicable, which means your OASIS data set should be introduced with these. Coming to the first two measures, the measures are need not be removed from OASIS data set, but then for value-based purchasing calculations, you just need not include them. So here, these are how the payment adjustments going to be. In 2019, it's going to be 5%. 2020, it's going to be 6%. 21 is going to be plus or minus 7%, and 22, it is going to be plus or minus 8%. Now, there's a slight change the way the calculations are being done. So value-based purchase is going to be calculated with claims data taking the precedence of 35%, the HH-CAP surveys taking the precedence of 30%, and then based on OSS data, 35% is going to be calculated. While 10% is going to be, out of this 35%, 10% is going to be allotted for the measures, recently introduced measures, because CMS thinks these are more appropriate in identifying whether the proper care is being given to the patients, whether the patients are improving or not. So they say these new measures needs to be definitely reported so that you can score 10% more. Then moving on to the next one, we have a quick poll coming up. Thank you. Moving on to the next one, quality reporting. This is more about the OASIS data. So the above changes which we spoke in VBP will be also considered here. And just want to reiterate that there will be 2% penalty loss for agencies who are not reporting the quality data. So out of the 2.2% hike which is happening, we think that it will not be applicable to everybody if they're not reporting the quality data. Coming to the OASIS dataset, there are 7 measures which are removed. 6 GG codes or the J codes are added for better assessments. 16 items are revised in terms of their coding options, skip patterns, and time point for the completion of the changes. While these are the changes with respect to quality reporting, just want to highlight one very important point, that providers need not submit how many long hours of care would be needed for the patients while recertifying, because they think the quality data will automatically give that information about the patient across different stages. So it's definitely a good breather for most of the providers. Then moving on to the most crucial component, which is patient-driven grouping model. The grouping model is going to become more intensified with different categories, like admission source, timing of the episode, which can be, the source could be from a community or an institutional, and then timing could be early or late. So they're clubbed together, and that needs to be captured when the patient is getting in. And then clinical grouping of the primary diagnosis of the patient is then categorized into 6 categories, which had very detailed or new diagnosis codes added. So all that needs to be identified. And then what is the functional level of the patient, whether low, medium, high, and if there is any other secondary diagnosis or the comorbidities, that also needs to be tracked. With all this information, close to 128 different payment groups are identified, and the system should not only track this information but also should identify the patient will fall under which group, and the corresponding HIPS code needs to be identified, and that needs to be submitted on the claims. So systems should have all the information, because this will decide how many visits would be required for the patient, and a proper scheduling needs to be done so that uh, within the 30 days, because the payment periods are now changed from 60 days to 30 days, the agencies should have a better planning for the respective patient to cover as many visits as possible within the 30 days to make sure that the patient is improving. Then therapy thresholds are no more calculated within the same claim. It needs to be submitted separately. Moving on to the next one, we are having a handout launched. You can click at the respective place to take a look at the handout. Uh, Next, what we have now, we have seen all the different changes across different aspects of the application. So what we have done is we have categorized these things into different stages of the workflow that the agencies will be following for each patient. So at each stage, what are the changes that needs to be taken care, and how the processes needs to be identified to make sure these changes are seamlessly integrated into your workflows. Now, starting with the patient checking in, where the initial administration is happening. At this stage itself, the source, the admission source, then the timing, and what is the primary diagnosis, under which bucket it's falling, the details of the diagnosis, if any comorbidities are there identified for the patient, everything needs to be tracked. Similarly, the rural add-on code also needs to be tracked, because based upon the county category, uh, the respective percentages will be applied. So for calculating everything, all these details needs to be tracked in the system, and system also should have the capability to help in calculating the right things. So uh, eligibility checks also needs to be performed to make sure that the payments are being received in time, and while all this information is captured, system should also suggest the agency's staff the number of visits that would be required for the patient based upon the patient's conditions, and the new case mix thresholds, because the as I mentioned previously, it needs to be submitted within 30 days for the claims. So there should be a robust scheduling capability also, so that patient is getting the right slots. Then moving on to clinical exam, uh, the therapy visit should not be included as part of the calculation. So that needs to be excluded, that needs to be planned differently, and the claims also needs to be generated accordingly for that. Now, the next one is care plans needs approvals from respective providers. So the whole process should be in place so that the triggers are indicated to the respective providers or the practitioners, so that they are well updated and they are signing the things. Then coming to OSSD at this stage, because during the clinical examination, the OSSD measures are captured for the respective patient during the assessment. So the measures also needs to be updated and the calculations needs to be updated. Uh, then we also suggest that line standards are good for capturing the assessments so that it can be exchanged very easily. Moving on to the care delivery. This is where the remote patient monitoring and home infusion therapies are now getting into picture. So there should be capabilities built within the process to receive the information from different telehealth devices for as part of remote patient monitoring. And coming to home infusion therapy, as there is a lot of regulation based on what is being given to the patient, for how much long the visit is going to last, and whether the drug which is being infused is under the covered list or not, the dosage is under the covered list or not. So if there is an alerting system which actually helps the staff of the agency, it will be very helpful, so that uh, wrong information or they don't cross the actual thresholds where
I believe, Kirti, you are facing connectivity issues. I apologize to all our attendees. Just give her a moment on that.
uh, uh, yeah, thanks, Gino, for that. um, I also, while talking about the care delivery, I just want to reiterate on the copy workflow, because uh, performance improvement is a very crucial factor which CMS is driving to achieve the outcomes of the patient. So a robust tracking system should be there, where the complaints of the patient are received, they are immediately addressed, and the resolutions are actually or the care plan is designed accordingly to meet the patient needs. So that is with respect to care delivery. Moving on to billing, as all through I've been talking, there are going to be a lot of changes with respect to billing, right from case mixes, identification of case mixes, thresholds, wage index changes, the base prices are changed. So the calculation should be dynamic, because this happens every year. The capability should be there to automatically calculate in the system. New codes are introduced, new add-on codes are introduced. The FIP codes needs to be submitted for the rural add-ons. So it's going to be a massive change with respect to the billing processes, so that everything can be taken into consideration before submitting the respective claims. Uh, while that's on the billing, moving on to reporting, as OASIS dataset is changed, the alerts are educational information should be enabled on the data set to capture information at different stages of the patient treatment, so that the scores on top of the OASIS or the quality data will help the provider meet the respective thresholds. So we suggest building some dashboard which helps the providers track where exactly they are and how much more they need to score in order to meet the necessary thresholds will always help them do better. Uh, then yeah, while these are all the major changes, I just want to have a quick poll question. This is more just to understand which aspect of your application is going to get impacted, whether clinical, financial, or both. What do you think about it? Thank you. So this is what we have put how to go about it with all these changes. So by now, we assume that you are compliant with COPs. If yes, then these are the next respective actions that you need to take within the system to go forward. So we have identified the changes as some of them as clinical workflow changes and some of them as billing workflow changes. So let me quickly take you through them. Now the case mixes and the outliers, respective charges and everything are modified. So your charge sheets should be modified. Your base rate or the standard rate will be changed. So correspondingly, the calculation should be there within the system that actually helps in calculating the standard rate into the case mix weight, which actually gives the adjustment payment. That into 0.761 into wage index for identifying the labor portion. Um, uh, and then the adjusted payment into 0.236 for identifying the non-labor portion. Adding the labor portion plus non-labor portion with NRS add-on, which actually gives the respective resource grouping value, which will go on to the claim. So I assume that these calculations or the formula should be there so that the base rates can be modified, and this actually calculates the respective charges. Uh, that is one. The next one is with respect to value-based purchasing. There are again slight changes with respect to the formula and sorry, the rates and with VPP, there is going to be data set changes, so that needs to be corrected, and the respective alerts or the alerting capability should be introduced. Then moving on to PDGM, patient-driven grouping model, a calculator should be there, a workflow should be there, the capability to do the complete data capture should be there, and then because the billing periods are changed from 60 days to 30 days, respective tasks or the frequencies that triggers needs to be modified. The scheduling needs to be more robust, helping the staff to schedule better visits for the patients. Then based upon the data points calculated as part of grouping model, the number of visits needs to be calculated. Then per visit LUPA payments needs to be done. Those capabilities should be there in the system. Rural add-on codes should be applied based upon the area or the county code of the patient. That needs to be there in the system. Then the other complete new feature is remote patient monitoring. So there should be a capability to receive data from the patient and to send the respective treatment plan to the patient. So bi-directional, it needs to be there. And when someone someone is going and meeting the patient, the number of hours or the visit should be captured. That can also be built, and respective codes for remote patient monitoring should be added to the billing system, and the same should be built on the claims. So the billing aspects of RPM also needs to be introduced. Coming to non-routine supplies, these are separated now, so that needs to be, again, the workflow change should be corrected to help them bill separately. Then home infusions, as I told, these are going to be get paid. So the respective codes are available for that. Those also, while the system changes are also there, because only certain drugs in certain measurement can be prescribed and can be paid when administered at home. So the visit should be captured, the DRG code should be captured, and the respective billing code should be captured to generate the claims. Then finally, the quality reporting, the measures data set needs to be modified. There should be rules in the system to help the providers to take the respective or the agency staff to take the respective actions for the patients to actually track that the patient is improving. So these are some of the major changes that we have identified that should be built within the system, so that the 2019 regulation can be definitely met. Uh,
Thanks a lot for that, Kirti. I believe the presentation gave us an insight of all the changes that have been introduced. All right, then, we'll be taking questions now, and anyone with a question can either raise their hand by clicking on the hand icon or ping us the question through the chat window. And during the last few slides, we did have a question coming in from Linda. Linda, I am going to unmute you and you can speak out your question. There you go. Linda, are you there with us? All right, then I will be addressing Linda's question. Her question was, which states will PGM be affected and when? Well,
so this will be applicable. Hey, Linda. This will be affected for all the states, and this should be rolled by 2020 January 1st.
Linda, if you're still with us, I believe that answers your question. All right, then we've got another question coming in from Chris. Chris, I'm going to unmute you and you can go ahead with your question.
Hi there. Well, most of your presentation is Medicare focused. I understand that value-based care model and the reason why the major players are embracing it. But we cater to huge population here in Nebraska. However, we do not bill Medicare. Our current focus is minimizing care gaps and improving quality of care. Are there any regulatory changes for the private markets also?
Hey Chris, while to exactly answer, there is no any regulatory change for the private markets, but most of the payers are moving towards value-based care to make sure that the right treatment, or instead of volume of treatment, the outcomes are given preference. So in order to achieve that, all these systems are very much important to incorporate more processes, more transparency, and more control over the patient's improvement. So these would be definitely required to have a better treatment and better care.
Uh, Chris, I believe that answers your question as well. And thanks a lot for that, Kirti.
Yes, thanks.
We've got another question coming in from Erin. Erin, again, I'm going to unmute you and you can proceed with your question. Erin, I guess you must have muted yourself. All right, then I will be reading out Erin's question. Erin wanted to know if we anticipate Medicaid adopting a VBP. Kirti, would you like to take that question?
Yes, because the VBP, the concept of VBP is mainly to improve, as I just told you, know, to improve outcomes for the patients. So uh, at the moment, I cannot exactly answer this, but yes, we can check and get back to you on the uh, plans of Medicaid.
Thanks a lot for that, Kirti. Does anyone else have a question that would be addressed? All right, then I will take your silence as a no. Then, and before I would like to conclude, I would like to thank everyone for your time and patiently observing the shared content. A recorded version of this webinar will be available soon on our website, and we will be sure to share the link with all the attendees. You can reach out to us if you have any questions or clarifications, and we will get back to each one of you personally and have those answered. Please feel free to drop us an email if you would like to discuss in detail around the things that we presented today. We would be happy to share our thoughts around the scale of change and the details of the suggestive approach that we spoke about in our concluding slide. I guess all of you have received an email from Samuel Thomas, from which you received the webinar invite. Feel free to drop a note on the same thread. Thank you once again. We would love to hear back from each and every one of you, and have a good rest of the day. Bye, everyone.